Hi, I'm Jack Cush, Executive Editor of RheumNow.com. It's the 24th of June, 2016, and this is the RheumNow Week in Review. This week from the social media feed, we have a few interesting items. A study of patients with Sjogren's syndrome looking at the risk of lymphoma analyzed a fairly large cohort and looked at risk factors, these 7 risk factors: swollen glands, lymphadenopathy, Raynaud's, either Rho positivity or LA, SSA, SSB, rheumatoid factor, a monoclonal gammopathy, and low complement levels. And if you had some combination of these risk factors, you were at higher risk of developing lymphoma. If you had 2 or fewer, you had very little risk. But if you had between 3 and 6 of these 7 risk factors, you actually had a risk of nearly 40%. If you had all 7, 100% of those patients developed lymphoma. So interesting data on who may be at risk for lymphoma. We reported previously on the Fascinate study. This is a very novel study of tocilizumab in patients with early scleroderma, systemic sclerosis of less than 5 years disease duration. Now it's been published in Lancet, 87 patients randomized to receive either placebo or tocilizumab 162 milligrams per week. And in the end, they had 24-month and 24-week and 48-week outcomes, showing a trend towards improvement in modified Rodnan skin scores, but a significant improvement in one of the secondary outcomes, which was the forced vital capacity being improved. We await the larger phase 3 trial, which is now currently enrolling. A nice review looked at patients with suspected fibromyalgia, specifically 373, and the predictive utility of doing either TFTs and CPKs, that's thyroid function test and muscle enzyme testing in such patients, and largely it has absolutely no predictive value. You discover almost no patients with either myositis and very few patients with occult thyroid disease, hence don't do those tests. A study of morning stiffness from a fairly large cohort showed what we wrote about a few weeks ago in a feature article called Morning Stiffness Madness, where I went off on morning stiffness as a poor historic feature that we often ask about and maybe hang our hats on too often. It's not all that useful, certainly not in inflammatory arthritis or distinguishing inflammatory arthritis. But this study showed 2 things. One, it did not correlate very well with disease activity score if you're looking at morning stiffness duration, but that if you were going to look at morning stiffness, it was better to look at morning stiffness severity rather than duration of morning stiffness. A nice orthopedic trial that compared 3 different treatments to patients who had non-septic olecranon bursitis looked at the outcomes for patients who were treated with either nonsteroidals and compression, 85% improved, aspiration with intrabursal steroid injections, 85% improved, and just aspiration alone, only 65% improved. Now, while the size of the study limits significance between these 2, clearly aspiration alone is not the way to go. A study of over 140,000 UK patients in general practice in Great Britain looked at the frequency of pain and found that 43.5% of the general population has chronic pain. This is not that different than some of the statistics seen in US population studies. The frequency of widespread pain was 14%, neuropathic pain 8%, fibromyalgia was 5.4%. A nice case report looked at the occurrence of saddle nose deformity in association with sarcoidosis. And we tweeted that you should now add that to your list of the differential diagnosis of saddle nose deformity that would include relapsing polychondritis, Wegener's granulomatosis, GPA, and even syphilis. Now you can add sarcoidosis. Studies from both UCLA and from the University of Pittsburgh looked at the outcomes of patients who had lung transplant with systemic sclerosis and found that the outcomes are actually no different than other disorders, including idiopathic pulmonary fibrosis. Heretofore, the idea of doing transplant in patients with scleroderma was a no-no, but these large centers that specialize in scleroderma and transplant have shown that you can successfully transplant such patients, and that this literature sort of suggests that. A CDC report has looked at the frequency by which we wear seatbelts here in the United States, and it showed that depending on where you live and under certain circumstances, between 10 and 24% of the population does not wear a seatbelt. Shocking statistics in this day and age, especially in light of the fact that there's very good research showing that motor vehicle accident fatalities are augmented by 45 to 60% when you don't wear a seatbelt. So again, I think that's something we can do ourselves and also enforce with our patients. A nice review of 486 patients followed for 5 years with a diagnosis of giant cell arteritis, looking at infectious outcomes, showed that the risk of infection was highest in the first year. Moreover, risk of infection, including death from infection, was higher in those who were older. That's that population, but the older, the worse. Diabetes, and if you were on steroids at greater than 10 milligrams after the first 12 months, meaning prolonged high-dose steroids were more likely to be associated with significant infectious risk that might lead to fatality. A large population study of patients with hypogonadism was analyzed for its association with autoimmunity. Why? Because we know that testosterone is somewhat immunomodulatory, and males have less autoimmune disease than do females. So they looked at a fairly large cohort, over 123,000 patients with hypogonadism, and looked at the frequency by which they would develop autoimmune or rheumatic conditions. They compared that to in a 1 to 3 manner with the general population, and found overall that if you had hypogonadism, you had a 33% chance of developing autoimmune disease. Specifically, you had a 31% chance of developing rheumatoid arthritis, and a 58% increased risk, not a chance, but it was a 58% increased risk over low population risk, but nonetheless, it was increased between 31 and 58% of the time. And lastly, we published the new EULAR guidelines on Behçet's and the management of Behçet's. You can find that on the website. For instance, it says that any patient who has posterior involvement with eye disease should be treated, and certainly be treated with an autoimmune disease, including Imuran and corticosteroids. They said that there's also no firm guidance on how to manage patients who have major vessel disease, thrombotic events, but that they did recommend the use of immunosuppressants, including steroids, azathioprine, cyclosporin, or cyclophosphamide. There was no data and no good guidance about the potential use of anticoagulations or antifibrinolytic agents in the management of such patients. Colchicine is the preferred agent for patients who have arthritis. And again, there's a number of recommendations regarding the use of skin disease. Interestingly, they did not mention the utility of the new therapy, apremilast, which has one study showing an advantage for use in patients with Behçet's. That's it for this week's RheumNow Week in Review. For the citations and links for those featured items that we've mentioned here, you can go to the website rheumnow.com and find the Week in Review under the video tab or under the featured tab to find these citations. Be sure to follow RheumNow for the wonderful world of rheumatology and information that is germane to the practice of rheumatology. You can also follow us and review this Week in Review on iTunes. That's it for this week. Enjoy.